developmental disabilities is the aging process actually starts earlier, about a decade earlier in those individuals than it does in the typical population. So what you might see with somebody who's 70 years old in the general population, for those that have chronic conditions, cerebral palsy, Down syndrome, you may actually see in their 50s and 60s. So just keep that in mind, because again, as practicing PAs, when you're out there, you may see individuals that have such conditions, and so be thinking about that. Don't use just age as the earmark. If they have some of those chronic conditions, you may need to look at them and consider them more in that age population. So in terms of the learning objectives, I won't read them to you, but we're going to talk about kind of the prevalence and incidence of falls and why they're important. Really looking at and dissecting posture and gait, and why that contributes to what happens as people age. And then you will be involved with fall prevention and really talking to those in the elder population about things that they can do within their environment, things their family members can do to hopefully prevent some of these things from occurring. And so when we look at falls, we're going to start off with a definition, which may seem a little silly, because you're like, a fall is a fall, right? But it really is kind of on a continuum. So it is an event which basically results in the person coming inadvertently, so it's not intentional, to the ground or another lower level. And I think that other lower level is important, because it could just be as they're transferring, they lose their balance and they end up making it to another surface, but it still wasn't kind of an intentional, purposeful activity. So any losses of balance, all of those things really would be still considered in that fall category. So it does include things like slipping, tripping, falling into other people, losing your balance, and knocking into somebody as you're walking around the grocery store, other places, losses of balance. A lot of times elders will say, and I just recently, my best friend's mother had a fall, which she said her legs gave way. She didn't call it a fall. She still, to this day, even though now she has a bimalleolar fracture as a result of that, still will not say she fell. So part of that, I think, is pride. They don't want to admit that they lost their balance, but all of those you just need to know. So, and that last part is, if a patient is found on the floor, you have to presume that they've fallen. And again, I'll give the example of my best friend's mother. She would fall, and my friend would come home, find her on the floor, and she would say, "Mom, what are you doing?" And she's like, "Oh, I was just down here looking for something." Aww. So again, it's one of those things. It's like, well, how long have you been down there? And so you have to presume that they fell. And again, they will make up all sorts of stories about why they're down there, how they got down there. It's a pride thing. So just take that with a grain of salt. As a provider and as a practitioner, you have to assume that the fall did occur. In terms of fall statistics, again, not going to go over all of this, but it is important for you to realize that everybody falls, and lots of people fall. And the older people are, especially 65 or older, the prevalence is even greater. I think the concerning part is that those individuals who fall rarely tell their physicians or their medical providers, unless they are prompted and asked. And even when prompted and asked, a lot of times they won't disclose that. So you may see bruising, you may see some other things, they may talk about pain that they've had, and it's as part of that process, the interview process about, well, tell me how this happened, that you actually then may learn information that tells you, yes, indeed, they did experience a fall. And then once a person falls once, it actually doubles their chances of falling again. So that's why detecting this early and understanding and trying to dissect really what is the problem and what factors are contributing to that or could be playing a part in that becomes critical. A lot of falls do cause serious injury. There's been lots of question over the years in terms of fractures that happen, but 95% of hip fractures are caused by falls. And in the orthopedic world, it really is a question of, is it the fall that causes the fracture, or is it because basically they break a hip and then they fall as a result of that? So it's like, which came first? But what we do know is that a high prevalence of falls do result in hip fractures. And of course that becomes even more so in winter months, if you're dealing with ice, if you're dealing with up and down steps, environmental factors play a role in that. Falls are very expensive, and that's in terms of healthcare, that's becomes very problematic, and why we need to look at, and it's important to try to prevent some of those from occurring. And then in terms of hospital costs, you can see that hospital costs for a fall injury, of course, those are going to be some very extreme that require surgery if you have a hip fracture, on up to just minor things, but the cost can be over $30,000. And as people age, the cost of treating those injuries that are related to falls actually increases. So we want to try to prevent that again. So I'm sure you all have seen, and the commercials are still on there, although they're late at night, my fallen eye can't get up. And that really is, again, so looking at supports that are available for community dwellers that may be living independently on their own. If they experience some sort of fall, do they have a mechanism to call for help? So they're not just sitting there, on the floor by themselves for an extended period of time. Institutionalized elderly, so those are elderly that are in some sort of long-term care facility, or even a smaller, 6-bed facility. They have a higher rate of falls, and more than 2 out of 3 fall every year. Now, why do you think that is?
They're more sick.
Okay, could be that they're more sick, so they require more care. What else?
Drugs, there are medications that might create instability.
Okay, so medications, usually, again, those are our most frail individuals that tend to have lots of medications that may not be monitored, even though they have a physician or a PA who comes and sees them, who's monitored, maybe a pharmacist that comes in if we're lucky, that monitors all of that. So is there good care coordination amongst the providers? And then the bottom line too is that there's not, in community environments, sometimes there may be people, I think the assumption is that they're provided 24-hour care in those facilities. But the bottom line is it's not one-to-one care. So you may have one staff person that's responsible for 8, 10, 12, 15 residents, and if a person calls in sick, then they're even responsible for more residents in that. So the risk of that, if there are things like memory issues or factors, they may not be aware that they're not supposed to get up. They're used to doing things on their own, so they get up and try to do things without having to call for staff, and then that can put themselves at risk. So there's lots of reasons that people in institutions have greater risk of falling. And then lots of people are treated for emergency room departments related to fall injuries, and again, many are hospitalized as a result of that. So when we look at that and we think about falling, and it's like, well, okay, that's great, but what keeps us from falling? And that really ties us into balance. So if we look at what is balance, it's a complex process that really involves the reception and integration of sensory input. So it's all the information that you're receiving from the external environment. You're taking all of that in, and then you're planning the execution of, this is what is going to allow me to put one foot in front of the other, to go up these steps, to achieve whatever goal it is, and basically that is to maintain an upright posture. So it sounds easy, but it's a little more complex than that. So really simply, it's your ability to keep your center of gravity over your base of support. And you can all think of situations when you may have fallen yourself. I can think of when I was on roller skates. Again, it's a different surface. Hadn't been on roller skates in many, many years, and you have a tendency to, have greater sway in your body, which gets that center of gravity outside your base of support and puts you at greater risk of falling. And the other thing is looking at the environment that you're on. Again, roller skates versus, regular shoes creates a more fluid environment that you have to deal, you have more degrees of freedom that you have to contend with in order to keep that balance and remain stable. So it is a dynamic system that looks at not only the environment, which we've talked about, it looks at the motor output. What am I trying to do or accomplish? Is it just me standing here? Do I need to walk up and down steps? Again, am I roller skating? Am I on ice skates? Am I swimming? What is the motor output that I'm trying to execute? Sensory input, so how do I perceive things in my environment? What's going on around me? There's a degree of cognition to that. So the motor planning piece, how do I, do I remember, is this a task that I've done before? Which then ties into the task. So just looking at that in and of itself, you think, well, there's multiple components within each one of these. And so when we look at postural control, which is our ability to maintain balance, you look at all of these components that come into play. So again, you have your musculoskeletal components that includes range of motion, strength, endurance, somatosensation, which is proprioception and kinesthesia. Do I understand where I am, where my body is in space? If you look at internal representations, again, that's my habits and routines. You all don't have to think about kind of how you get from one place to another. It's just kind of an automatic thing. And so as we age, our ability to process that information and how we can adapt to that information becomes a little slower. So our speed of processing becomes slower. And a change to the environment when we were younger, we may be able to adapt to, but as we get older, we really have to consciously think about the steps that you need to do to alter the pattern in order to remain upright. Again, adaptive mechanisms such as problem solving, organizing, and recall become slower and less fluid as we age. Which ties into anticipatory mechanisms, so those are things like vision, cognition, judgment, decision making. We may not be able to make decisions on the fly. We may need more time to actually really think about how am I going to traverse this kind of rocky environment versus if you're just walking in a smooth path. And then what tasks we're doing. So that's the activities of daily living that you do regularly. That can be as part of your education, your work, and the roles and contexts that you play within that. Your individual sensory system. So again, we're talking about vision, we're talking about your vestibular system, and somatosensation. When we talk about neuromuscular synergies, that's where we're getting into coordination, muscle tone, movement synergies that we tend to use. And again, our posture may negatively affect some of those. So because and then if we've had some sort of brain accident or a brain injury, the movement synergies that we have available to us may be impaired. And so all of these have the potential to cause problems with our postural control, which then is going to relate to our more difficulty with maintaining balance and, again, prevent falls. So when we look at who is at risk for falling, you can look at those that have deficits in any one of those areas. But if you have lower body or trunk weakness, clearly that's going to put you at greater risk for falls. If you have difficulties with gait and balance, the limitations in postural control and range of motion, and dizziness. I think part of the challenge is trying to sort out, as we're looking at, which part of this is really the key factor, because they may have perfect strength, range of motion, and endurance, but have difficulty with coordination, with movement synergies that really relate to that. So how do these things tie together, and really sorting out which one is causing the problems so that we can positively impact the result. If somebody has vision problems, they're not going to be able to anticipate changes in their environment. They may not actually see steps, which puts them at risk for falling. We talked about, when I discussed the did the lecture on diabetes, we talked a lot about foot pain and foot care, and the impact that has, poor footwear has on the prevention of pressure ulcers. The same goes true for balance and gait disorders. So if you're looking at people whose shoes are too small or too big or whatever it is, don't fit appropriately, and that in and of itself can put somebody at risk for falls. Home hazards is probably the biggest thing that we forget to ask about, but is a huge factor that relates to falls in the elderly. So really looking at, and we'll dissect that a little bit more later in the lecture, about really taking an environmental scan and looking at it and making sure that it's as decluttered as possible, and you remove any unnecessary hazards. Somebody has vitamin D deficiency, again, that's going to have the potential to put the person at risk. Postural blood pressure changes, so orthostatic hypotension is a real factor that can potentially cause, so if they change positions too quickly and their blood pressure drops, then they're going to become dizzy and they're going to be at risk for having to, again, maybe not fall, but as they stand, they become dizzy, they have to sit back down. Technically, again, if you look at the definition that we talked about earlier, that would be considered a fall. If you look at low mental status and depression scores, those are also going to have an impact on or put them at risk. If the person has 3 or more falls in the past 12 months, they're going to be at higher risk for future falls. Remember, even if they just had 1, they're twice as likely to fall in the future. And then, as Dr. Britton pointed out, people that have multiple medications, which many elderly have multiple medications that may not be managed well, we have to look at those medications as a potential culprit in their fall risk. Other reasons that people fall, again, environmental factors, so things like dim lights. Do they have any natural light in their home? Is it real dark in the home? Which puts them at risk for not recognizing things that may be on the floor and tripping over them. Throw rugs. Again, I can remember my grandmother having throw rugs everywhere in the house, and she was very proud of them. So, the mention of potentially changing or moving the throw rug that had been there for, 40, 50 years was just not something that she wanted to have a discussion about. But yet, it definitely can be a fall risk. Slippery floors, and that could be because of something they themselves spilled. It's especially important as we're talking about bath time routines. So as they're getting in and out of the bathtub, in and out of the shower, those are going to be common places where you see, and actually my best friend's mom, that's what happened. She was getting out of the bathtub, and that's when, and trying to transfer back into her wheelchair, and that's when the fall occurred. If you have uneven or non-level surfaces, such as pavement, sidewalks, driveways, then that's going to have a potential. There's lots of disease precursors. Again, you can look at the list and see that, but they're those things that are going to be related and put them at increased risk, and a lot of times it's because of changes in their gait, or they just don't have the problem-solving ability that they need to be able to think fast enough on their feet to be able to make those postural adjustments that they need in order to prevent the fall. Dizziness and vertigo, there's multiple causes that can lead to falls, and again, it's regardless. So that's where if somebody's complaining of dizziness or vertigo, it's really trying to dissect what is the culprit. Is it something within the inner ear canal? Is it something within their other vestibular systems that are contributing to the fall, and trying to sort that out. Lots of medications that have the potential to cause falls and the reasons for it. So like the sedatives can cause dizziness or drowsiness, so they're just not as alert as what they would be if they were not taking the medication, so that is going to put them at risk. So each one of those lists kind of what are the symptoms that they may be describing on the medication, or they need to be aware of when they're taking the medication to know. You may experience this, and if you experience that, you need to be careful about doing X, Y, Z. And it could just be you need to be careful about walking about, because these are potentially things that could happen. You can talk about timing of the medication, so you may not want to take these medications prior to taking a shower or bath, because you're going to be on a slippery surface, you're going to be at risk anyway, so we really need to think about trying to time it so those activities occur maybe at a time where they're not experiencing those symptoms. And then, of course, not that any of us have ever experienced this, but alcohol can be a contributing factor for us maybe not being able to maintain our upright posture. So, medication relating to fall risk, lots of medication, and I'm sure Dr. Britton and Dr. Latassi will probably hit over and over again, knowing the Beers criteria. have you covered that yet?
That's tomorrow morning.
Okay, so you will get that, and I'm going to leave it to them, much more of an expert than myself, but making sure you've got 2 links here that you can use to examine that. I think the important part here is anytime you're starting on any of these medications is to start slow, go slow. And if there is any chance of or possibility of avoiding polypharmacy, which is multiple medications, then again we need to try to do that. Now, I'm not Pollyanna. I know there are times that people require the use of medications, but that's where we want to consult with our pharmacy colleagues and others and say, is there a way that, again, the timing of medications can be such that we can reduce the risk or the likelihood that they're going to interfere with their ability or put them at less fall risk with those medications. Or are there other medications that we can consider that would do the same thing but maybe not put them as at high fall risk? In terms of psychological consequences of a fall, and I think this is why a lot of elders don't want to admit that they've fallen. I think once you have a fall, and if you all can think about times you fall on yourself, I mean, it's kind of an embarrassment, I'll admit, you know, I'm jogging along and slip and fall, and the first thing you do is like look around, did anybody see that? And you immediately start like, okay, is this the beginning of the end here? Have I already hit that age? So thinking about loss of function, is this something I'm going to be able to continue to do? Does this mean I'm going to be less independent? You do kind of get this lack of confidence, so it kind of shakes you up for a while thinking, am I going to fall again? Is this going to be a regular occurrence? And I can, again, give this example of my friend's mom. She's 76 years old, sustained this, and the first thing she said, well, I'm 76 years old, this is the first time I've had a fracture. And she said, what's going to come next? And I'm like, well, I'm looking at you thinking you're 76 years old and this is your first fracture. That's a really positive thing in my mind, but in her mind, it was totally, she was already like, what's going to happen next? And so really trying to talk with her and reframe that. You're really fortunate. There's people a lot younger than you that have had multiple falls and are probably at much greater risk. So the fact that you've made it to 76 years of age and you've never experienced anything, that's a positive thing. Now, she had fallen before, but hadn't sustained a fracture as a result of that. So it's really looking at and talking to her about examining kind of the situation in which she fell. And she doesn't like to admit that she needs help. And so really talking to her about in situations like this, when it's a slippery surface, when you're getting in and out of the bathtub, you may need somebody to be there to assist you. And as you all can imagine, you know, a person being independent all their lives and doing these things, thinking about having to have somebody else in there with you is not something, I mean, it's a humbling experience. So trying to understand it from their vantage point of, they may know they need it, but it's still like, I can still do this myself. And so in her case, really putting herself at greater risk because of that. They don't want to develop dependency on others because immediately when they think, if I become dependent on others, what's going to happen next? They're going to put me in a home. You know, I'm going to be institutionalized, whether we like it or not. And sometimes that, and in my best friend's mom's case, it's a real thing because you know, my friend has to work 2 jobs. And so in that case, she's left with thinking, okay, do I leave my mom at home? She falls. I don't find her until 8 to 10 hours later because she doesn't have a way to call for help. You know, am I putting myself at risk for being reported to DHS or, you know, so those are all real things and we have to dissect those within family dynamics and figuring that out. Versus do I put her in a home where I know she's going to have people there that can help support, that can help manage medications, because that's the other thing. You know, she's used to taking her medications on her own. Is she taking them at the right times? Is she taking them consistently? Or do we have other factors that are playing into really the ability of her to be able to manage those things herself? It does get to be a period of, or a concern about social isolation, because they become fearful of even getting up and moving around on their own, so they're less out and about in the community, and they do become more solitary. So unless they have people that are coming in consistently checking on them, if they have a good system of supports in family, then that social isolation may not exist, but it is something to be wary of. And then all of those things kind of combined can lead to the feelings of depression, anxiety, and confusion that may occur. So when you have somebody that experiences some sort of fall, and depending on the what happens as a result of that, if they sustain some sort of injury, you often have a consequence of immobility. So whether it's because they have a fracture, so they have to be stabilized, whether it's because they have surgery, and so they're in a hospital for a period of time, they're probably not going to be immediately, unless it's just a small, a fall that doesn't have any secondary consequences of that, but they may be immobile for a period of time. And then that leads to a host of things that we have to be concerned about with immobility that can, again, also then impact their balance when they do get up and moving again. So oftentimes they have decreased intake by mouth. They are at risk for developing DVT, so we want to keep people up and moving as much as possible. They're at risk for having a pulmonary embolism. We talked about pressure sores, constipation, fecal impaction, urinary incontinence. So all of these things, and if you look at some of these, you're thinking, oh, well, that's also going to put them at risk for a fall. So it's this double-edged sword of we want people to maintain their mobility as much as possible, but how do we do that in a safe and effective way so some of these secondary complications don't occur? So what we have is, this is all the things that can happen, or an example of things that can happen when people fall. So hip fractures is, again, one of the things that I talked about, which is very common as people fall. You can get all sorts of bruising in very obscure, sometimes, places, and you think, what in the world did they hit on the way down? And sometimes they may not be able to tell you that. Whether it's because they're fearful, whether it's they do have some sort of memory lapse, like they truly may have had a concussion on the way down, so they may not understand what hit and where it hit, and so again, just trying to recreate the process as much as possible and get as much information out of the individual is important. If they don't communicate, so if they have difficulty communicating what happens, that makes our job all the more challenging. Hopefully, if they have family members that can help, they can at least say where they found them. If there are caregivers in, a skilled nursing environment or in a nursing home environment. Now, I will say getting information sometimes from staff within those environments is very challenging, because what are they worried about? I'm hearing mumblings, but yeah, being sued or being blamed for not being there for the person. I mean, that's what goes through their minds. And so trying to put those individuals kind of at we're not here to blame anybody, we're just trying to figure out what happened so that we can, put procedures or steps in place to try to prevent this from happening again. Now, even in the best of all worlds, sometimes people are going to do stuff they're not supposed to do. If there is loss of, if there's some sort of cognitive deficit, again, psychological changes that have occurred, we're not going to be. So I think they do institute, putting alarms on individual beds or chairs to try to alert them when the person is not doing, when they're getting up, when they're not supposed to without assistance. But trying to dissect, again, and getting as much information from those individuals as possible. On the upper right, you see a picture, again, our tendency as we fall is to, fall on an outstretched arm, which then puts us at all sorts of risk for wrist and hand fractures. Bruising, you can see along the person's thigh. And you can, again, look at the pattern of bruising and look at potentially what they hit as you learn about location. And then you can look at, on the bottom right is an example of a compression fracture that occurred as a result of a fall. So again, you've got changes along the spine now, which is likely going to create more pain, more immobility, and put them at greater risk for potentially falling again if it's not treated carefully. Other traumatic complications, so we have soft tissue injuries, which could be, again, just bruising, some sort of sprain or skin tear and lacerations. We can see all sorts of fractures that potentially it can happen. Obviously, the hip, wrist, and shoulders are the most common, although you can have a compression fracture like we just saw, and the ribs may be broken if they end up falling on something. Dislocation of a joint, so that is one thing that you hope, if a fall occurs, everything stays in alignment so we can avoid having to have surgery just to stabilize the fracture. In terms of other major injuries that you can occur is subdural hematomas and or fracture of the neck or spine. So a fall can result in actually somebody then ending up with a spinal cord injury, which is always a nice thing to have to deal with, and especially in the elders if have no ability to understand really what's going on. And at that point, unless there is somebody there to call for help, they just have to wait until people are there because they have no movement below the level of the injury. And then, of course, ultimately death can occur if they have any one of these things and help does not come quick enough. So in terms of skin tears, you can get anything from a minor tear. What we know is about as you age, the skin is more fragile. And so it does become less pliable. So if you happen to have a fall, just the pressure from the fall itself can cause some sort of skin tear, as well as the bruising that occurs as a result of that. So looking at, if they're going to require stitches afterwards, if they have to do some sort of skin graft because the tear is so significant that it is, and they have difficulty healing, then those are all things that could potentially result in that. So we talked about hip fractures that are caused by falls, and you can see on the right where you have a normal hip, and on the left you can see it's actually fractured and then actually displaced upward. And so those are things that we look for in that. Usually a femoral neck fracture like that is going to require surgical intervention, and depending on the stability of the hip, they may actually say, we don't think, and if they have osteoporosis, they may not think the hardware is going to stay, so they may look at doing some sort of hip replacement at that point. So again, that's where we'll have our orthopedic colleagues that are coming in to make a decision about the best option for that individual. They may decide in some situations, depending on their pre-existing condition, so what was this person up moving around? Again, I'll give examples of individuals with intellectual and developmental disabilities that I worked with who had sustained hip fractures. Sometimes the orthopedist would say, should we just leave this alone? And kind of let it heal even though it's in a position. They weren't up walking, they haven't been walking, they utilize a wheelchair to get around. I think they're at greater complications or risk undergoing a surgery because of these factors. So it really is a decision that family members and those who are going to be providing the care maybe have to face, which consequence should we face? Are they at greater risk? Now if they're a community ambulator and they're up moving around, then yeah, it's going to be a no-brainer. But if they had some sort of impaired mobility to begin with, then they may ask questions about what was their level of ambulation, what was their main form of mobility. If they do utilize a wheelchair, did they assist with transfers in and out of the wheelchair? If not, again, do we really need to look at some sort of surgical intervention, or should we just immobilize it and kind of hope for the best outcome from there? So when we look at fall-related deaths, some of the, and you can see that we actually see an increase in the rate in the population that has gradually increased from 2007 to current date. And what we know as in terms of fall-related deaths is that men are more likely than women to die from a fall. And why do you think that is? Heavier? Could be. Prideful? Is that what somebody said? Okay, some of you men speak up here. Defend yourself.
I'm trying to think of a defense.
Yeah.
Is So where they're working, like they do riskier.
Exactly. So if you think about kind of where do they fall from, so if you look at environments, they're more likely to be up on roofs, on ladders, on, you know, those sorts of things, which puts them at greater risk for, you know, a more traumatic event than it would be for women. Now, some of these other things may come into play. They don't want to seek help, so they may be experiencing like a subdural hematoma afterward, have a headache, not seek medical care, and then be at risk for, you know, developing complications as a result of that. But it usually is the mechanism of the injury is much different in men oftentimes than women. But if you're a woman who likes climbing ladders and cleaning out gutters like I do, then I might be just at risk as men are. So again, it depends on the activities that you're involved in. It's increasing among all persons greater than 65 years of age, but it's the fastest increases have been noticed for those 85 years and older, which goes to our previous statistics. The older you are, the more likely and the greater risk you have of falling. But death is also goes along with that. In looking at the increases over time, Oklahoma actually, and this is from one of the recent studies, Oklahoma had the second largest average annual % change in mortality rates from falls, which I thought was pretty telling. I have no idea why that is. It could be, and I don't know that our aging population is older than anybody else's. It could be lack of access to care, I don't know. But I did think that that was an interesting that we were kind of second on the list, not a positive thing. So it just alerted me to say those are all why preventative strategies are important for us as healthcare practitioners to make sure we're asking those questions for people that are coming in to see us about falls and things that we can do to prevent falls. Death rate from falls are higher among white non-Hispanic men than any other race and ethnic group. Again, don't really know this, you know, why that is, but that's how the numbers play out. Older white females are 2.4 times more likely to die from their falls than black counterparts, and then older non-Hispanics have higher fatal fall rates than Hispanics. And again, you just kind of go, this is interesting to try to figure out why. But keeping those things in mind, whether it be because they're not as open to disclose the injury, whether things are hidden for a longer period of time, whether they hide things that are going on, and so they keep kind of challenging themselves and then ultimately and don't disclose that they're falling, then those things are important.
I think one thing with older white females is that they are more likely to cause osteoporosis and brittle bone, so a white woman who falls, you know, is more at risk for a break, and a black woman is not. Right,
yeah. So Sentinel Events, and this is something that's defined by the Joint Commission, and that's an unanticipated event that happens in a healthcare setting that results in death or other serious physical or psychological injury. And so you can see these are the top 10 most frequently reported Sentinel events for 2017, and the second one on the list is falls. So we still have a lot of work to do, and this is, again, when they're in a healthcare setting. So you think, okay, you think they would be safer in a healthcare setting, but not the case. So we need to look at those. So we are talking about falling, which yes, it is a part of life, but making sure that we give individuals the ability to kind of overcome those falls and getting back up and getting back to the things that they enjoy is really our challenge, or the challenge to us as healthcare practitioners, to make sure that we put them back into safe environments and the ability to really get back up and do what they want to do. So the factors that now we're going to move into are talking about, okay, so we have people that have experienced fall, and we talked about the multitude of things that can contribute to a person falling. And so how do we really dissect and figure out what is it that led to that person's decline? So what we know is that as we age, we have physiological changes that occur in both our posture and our gait. And those things tend to decline over time. So what things can we put in place that can potentially reverse those things so that we increase the likelihood that they're going to be able to, we can prevent falls. So we have muscle weakness, atrophy, stiffness that results in loss of movement, stamina, and strength. That's why as physical therapists, and hopefully you all as PAs, will continuously encourage people to remain physically active. That doesn't mean that we have to all be running marathons or doing, but just whatever physical activity they have always been accustomed to doing, trying to continue doing that as they age becomes important. Looking at ways that we can modify activities. If they find themselves that they're not able to do things that they used to be able to do, how can we modify those in a way that will still allow them to remain physically active? For individuals with osteoporosis and arthritis, looking at both osteoarthritis and rheumatoid arthritis, can we look at whether it be medication control, can we look at maintaining that within some level of pain management that doesn't prevent them then from being physically active. They will tend to have decreased skin integrity, which can lead to not only problems, or not necessarily lead to falls, but can lead to secondary complications that occur if a fall does happen. Poor nutrition and poor absorption of nutrients, and then things that we all see at various times in our life, impairments of sensory systems. So sight, smell, touch, and sensation as we age definitely goes through some changes and can contribute to what happens. So when we look at poor posture, the diagram on the upper left is kind of what our typical posture is when you look at. So basically if you draw a line down through the middle of my body, my ear is going to be in line with my shoulder, it's going to be in line with my hips, and is going to go down through the center of my foot. You have a little bit of a natural curve in your low back, and so if you compare where your pelvis is, which is the line that's going down in between, your PSIS is going to be slightly higher than your ASIS. And when I say that, you all know what I mean, right? Okay, making sure, talking language. So that you have a slight anterior tilt in your pelvis, which is what we want. If you look at different types of what we call faulty posture or abnormal posture, in the A diagram, what you can see is you have more of a lumbar lordosis that occurs. You actually see even a further tilt, so they're more in an anterior pelvic tilt than what they should be. A lot of times that could be due to weak abdominals, tight hip flexors, so there's lots of musculoskeletal changes or strength changes that can occur. And then you can see where the ears now begin shifting a little bit forward of your shoulders. And then in B, you've got a lordosis that has developed, and this is, again, which came first, the chicken or egg. You may have had a kyphosis, which is a forward curve in your thoracic spine, and then the lordosis developed as a compensatory mechanism to, again, try to keep the body aligned. Or you may have had the lordosis that developed, and then the kyphosis was the counter, product of that. So either way, you have basically both a kyphosis and a lordosis that have occurred. And again, the whole reason for that is to try to keep the body in an upright, symmetrical position. In C, you have a very extreme, what we call sway back. So if you look at, if you have that person standing against a wall, their thoracic spine would hit before their lumbar spine, and they would probably be out from away from the wall. If you had them put their bottom against it, it would probably be even more exaggerated in their lower lumbar spine. And then in D, what you see is more of a flat back. So if you look at, they don't have kind of that natural lordosis in their lower lumbar spine, and their pelvis is more flat. So their ASIS and PSIS are more in line with one another. And then in the E posture, you have more of just a rounded back overall. So again, a more flat pelvis. In the lower left, you actually have, and if you remember doing scoliosis or going through scoliosis screenings in elementary school, middle school, that's typically how they look at it. And why do you see that sort of, what are you looking for when you do the scoliosis screening?
Alignment of the spine.
So alignment of the spine, but visually are you? Lateral curvature, okay, but what do you see present on, in this picture, you're looking at it? What is that that's protruding? The rib cage. It's called a rib hump, okay? Because a lot of times when we have a lateral curve of the spine, you actually have a rotational component to it. So what you see, the evidence that you're observing for is that rib hump on that side. So that's what we refer to that as. In the upper right-hand corner, again, you have somebody that has significant kyphosis, and once you do that, again, it's rounding of your upper spine. And automatically, and you guys can do this in your seat, if you think about your slump posture that you have, you automatically, your shoulders roll forward, which automatically puts your head forward. And if you think about even just mobility within that, you try to raise your arms above your head, and you're in this slump posture, you lose range. So, usually, you want your ears and your shoulders to be in alignment with one another. So really thinking about those rhomboids that pull your shoulders back, getting those engaged, sitting nice and upright, so that you don't end up like this when you're 60, 70, 80 years old. And then the bottom right is also just a greater exaggeration of the thoracic, and even going down into the lower thoracic and upper lumbar spine, into that kyphotic posture. So, if we don't deal with those changes in posture over time, then eventually we're going to have kind of some corresponding gait changes that have to occur as a result of that. So we really are in the prevention mode and trying to make sure that things do not get worse. So gait changes that we see as aging occurs, in terms of the cadence, the number of steps in unit of time. This really is something that people have gone back and forth in the literature. Some authors report decreases with age, others report that there's no change. There are cultural and social variations to that, but what we're looking at is normal is about 100 to 115 steps per minute. When we look at velocity of gait, we're looking at distance covered over the unit of time. Again, the average is about 80 meters per minute, or about 5 kilometers per hour, or 3 miles per hour. And you do see decreased velocity without any change in cadence. In terms of step length, what we know is that, again, as people age, so 75-year-olds, their step length is about 10% shorter than a 25-year-old when you adjust that for leg length. So they looked at, again, they know there's going to be some variation based on people's leg length, but when you adjust it for that, age does tend to be a factor over time. You see greater stance swing ratio, so you see less time spent in the swing phase of gait, so they want to keep both feet on the floor, so you tend to have a more shuffling gait pattern, those sorts of things over time. Less percent of the gait cycle, and again we talked about the gait cycle when I came and talked about diabetes and foot care. So they actually, the more that you age, the less time in the gait cycle you spend in that single limb stance. One of the things that we talked about in those with diabetes is you have the decreased ability to push off, so because of the lack of plantar flexion power, so the gastroc is not as powerful as what it used to be, and so again you have those same things that you deal with in individuals who are aging. A flat foot landing, so we don't have a nice heel to toe progression. They tend to be maybe with their whole foot on the ground, and then you also, because of some of the postural changes, you may actually see a decrease in pelvic rotation that occurs in the gait cycle. In terms of contributors to abnormal gait, posture, and balance, you can have pain that may be due to any number of factors, and those are listed here. So some of the things that we talked about, bunions, calluses, improper toenail care, that poorly fitting shoes. If they do have some sort of degenerative joint disease, then that's going to cause problems. And then obviously if they have any sort of stress or compression fracture, then that could be a contributing factor. So You can look at and do, look at their distal joints, both hands and feet, to look for swelling, to look for abnormal alignment. A lot of times they'll say they're complaining of pain. If you take their shoes off, you don't no telling what you'll see. So you can actually see where some of that is coming from. In terms of other contributors to abnormal posture gait, you may have stiffness or spasm that is related to some sort of arthritis. We talked about poor posture. And then poor posture can lead into contractures that may develop in the ankle because of Achilles tendon tightness. You definitely can get, for those individuals that rely on a wheelchair or do a lot of sitting in a recliner, then their hip and knee flexors become shortened, which a contracture is a permanent muscle shortening that takes a long time to overdo. If they have paralysis as the result of a stroke, then you can see that. And then also as a result of Parkinson's. I don't really remember, so I'm going to click this. Don't remember what it was. Oh, yeah, okay, so.
And these three patients show more significantly.
So I'm going to back it up because this is actually looking at Parkinson's gait and looking at a rating scale for.
These three patients show more
significant. Do this right. Okay, so we have the rating scale. So 0, if you see an individual, that would be normal. 1 would be walking slowly. They may shuffle with short steps. They don't have any festination, which is that shuffling that you see and the tremors that you see as they walk about. 2 would be walking with difficulty, little or no assistance. They may show some festination in their gait and the short steps or propulsion. And then 3 would be severe disturbance, and they require frequent assistance to 4 being they cannot walk. And this is just showing several different individuals.
These three patients show more
and their gait. So watch this, and then
they all
we'll
have
take a break.
Parkinson's disease. This first patient is probably the most effective. His stride length and arm swing are very decreased. There you can see his turning on block. He also had some slight freezing in that turn. The amount that his stride length is shortened and the festination interfere with his gait, making it difficult. Therefore, I would rate that a 2 on the PRS. The second patient has decreased stride length and some dystonia in the neck, which make his gait somewhat difficult. This third patient shows the response to medications that can happen in Parkinsonian gait. First, here we see him with significantly stooped posture. And then next with meds, he has better stride length, and although his posture is still affected, is improved somewhat. These three patients show.
Okay, so I'm going to leave that there. So